안녕하세요.
Hello, I'm Kim Jin-gu of the Yeonsei-gu Dental Clinic. I'm going to talk about the anterior implant placement and immediate loading with OneGuide system. So what are the considerations for anterior implant treatment? Typically, depending on timing of implant placement, we have such categorization. After immediate extraction and 1 week, we call it immediate placement. Placement after 1 or 2 months, early placement, and after 3 or 4 months, we call it delayed placement. So these are the generally accepted definitions. Immediate extraction is most challenging part. And we also talk a lot about immediate loading because just immediate placement is not everything because of their advantages. So we also do immediate loading together, and we do that all within a week. So why immediate placement? As many journals says, after extraction, we have a lot of bone resorption, and a lot of literature says that horizontal change is greater than vertical in terms of resorption, and buccal have more resorption than on the lingual side. So after extraction, we have weaker bone, and there is more resorption on the buccal side and more horizontal side. So in this famous article, talked about how the buccal bone is resorbed. First, we have the buccal bone resorption, and then on the vertical side, and then on the outer surface side is the second phase, becoming shorter. And then in 2017 says labial bone that is thin, less than 1 millimeter, has more resorption, but with the thicker soft tissue, we don't feel it, but once we place implant, that sort of disappears. So what we can glean from this is after extraction, if you want to place implant, there's a lot of tricky situations and there are no bones left. This is because of the bundle bone theory after extraction. Now, bundle bone is, if you by computer, you know, bundle bones come together like that. Bundle bone means it's a bone existing because of tooth. This means that in thin labial bone, after tooth extraction, the blood supply cannot exist inside because it's a very thin bone. So it gets vessel supply through PDL and maintained, but after extraction, it also all disappears. So the thinner the bone, the more resorption you would have on your hand. And as you can see here, and because of that, the case of very thick labial bone, then it's okay. But in most cases, it's helpful to do immediate placement. So immediate placement can reduce, in other words, resorption. But just immediate placement does not mean that you can avoid a lot of resorption. Without GBR, many literature says the bone inevitably result in resorption. Hence, immediate placement always goes hand in hand with GBR, especially for the anterior implant side. So immediate placement with GBR, they did on one side, and on the other side without GBR. In the GBR group, they saw less soft tissue contour change. So again, doing a GBR with the extraction, immediate implant placement with immediate GBR, aesthetically, stability-wise, in other words, is very much necessary. Depending on the biotypes and residual bone thickness, there's a lot of different theories, but thinner the bone, you have to do sufficient GBR. If you ignore all this and think that, you know, I can, you know, do later on implant placement, I will do a bit small GBR and do implant placement. If your approach is that, especially on the anterior side, and whether mandible or maxillar side, it's very aesthetic zone, and you could have aesthetic complications on your hand. So you could have a very serious soft tissue recession, and such soft tissue recession could happen when there's inadequate GBR. So you have to be mindful of that. So what is sufficient GBR? Most say that adequate augmentation after sufficient remodeling, if you have at least 2 millimeters of thickness, they say that's the good practice. Then, on the anterior side, doing provisionals, is it helpful? So when you do provisional crown, you could reduce recession and you could reduce other problems. Hence, if possible, if it's immediate implant placement, it's helpful to do provisionals. That's what all the literature say. And immediate implant placement and doing provisionals, it could simplify surgical procedures, and it could also provide instant aesthetics to patients. Because it's, especially anterior without tooth for a few months, is really hard, and it could also preserve bone and gingival contours. So if possible, immediate placement and provisionals, doing the loading at the same time, they say have a lot of different advantages. So guide surgery is more accurate than you think. So when you do implant placement, depending on the bone situation, sometimes 3 steps, but with the guide surgery, the positioning will be accurate. So prosthetic complications or aesthetic complications becomes less. So if possible, on the anterior side, a lot of different journals say the guided surgery is recommended. And for me, also 99.9%, I opt for guide surgery. Recently, on the anterior implant side, newest treatment modality have been summarized in this paper, and they say if possible, provisional restoration is what you need to do, and then atraumatic extraction is recommended as much as possible. Then when you place implant, you have to do good bone grafts and use surgical guide, put the customized abutment, and do provisional crown relining. So these are the recommended practices. So my approach is this. I do immediate placement following tooth extraction, guide surgery for ideal position, excess GBR with xenograft, and pre-milled abutment is used, because if you buy off the shelf, the top part cannot be sealed. So you have to close the sealing, and immediately provisional is delivered to have more aesthetically pleasing result and also have more functional benefits for the patient. Then let's look at the implant treatment on anterior maxillar side. I'll show you actual cases. Now for this patient, it was a young patient, number 21 on the central incisor. They had root resorption. It was a male patient, and I placed implant and did the guide surgery along with GBR. And as you can see here, root has been already resorbed, and extraction was planned like this. And as you can see, the implant positioning was mostly, it's better to go palatal, but if you go too palatal, there could be different issues. So this was the position that I planned, and after extraction, you can see the resorption was already happening. And as you can see, soft tissue was already filled, so I took it out, and there was a fenestration defect, and only very thin labial bone remained. Hence, using the guide, I placed implant. As you can see, the gap was rather big, so you have to do sufficient GBR here, and it's xenograft and AOS was used. And I did GBR, and using bone tech, I fixed it on the position. And for collagen membrane, in case of this, I used membrane because base was big, and if it goes the the augmenting coronal part, sometimes there could be no bone if it goes too on the back side. So because of that, with the sufficient GBR, and then I sutured the flap side and delivered provisional. And provisional crown is a bit short. If it touches the opposing tooth, and it was extraction site, and on the apex, 3 meters would have been fixture strength. And if it fixed on the lateral side, there could be loss. So under occlusion is the key here. After 2 weeks, suturing healed well, and the healing continued successfully up to 6 weeks and after 10 weeks. And you see slight resorption of the soft tissue, but the crown will be remade again anyway. So 2 crowns were made. It was a young patient in his 20s. So for aesthetics, link abutment was used and zirconia abutment was used. And after prosthesis was delivered, and after 6 months and 3 months, and up to follow-up for 2 years, and you cannot really tell which is implant and which is natural tooth. So form and other things are very much well maintained. So CT shows on the buccal side sufficient augmented volume exists, which I did, and of course it was resorbed remodeling, but still it remained after 1 year. So after that, I expect there will be less resorption on the PA side. The healing continued successfully and maintained very well. Now this was the result. We will see another case. For this patient, 50s female patient who was aesthetically very demanding, and there was a lot of severe periodontitis, so I had to extract it and use OneGuide. I did GBR, immediate implant placement, and deliver provisional. On the x-ray side, severely there was a region, implant was very much shaking, and palatal bone, as you can see, did not exist anymore. The apex, it was also region, and the bone here was also thin. So I think it was very hard to gain the fixing strength. So after extraction, I did simple extraction after drilling. Before I did placement on the labial side, we did the sufficient GBR here. So I did decortication first before delivering implant. So after drilling, this is just before delivering implant, because when you punch the cortical bone, you were afraid if there is a fixture or implant, you would punch hole there too. So if possible, just after drilling, before placing implant, you should do decortication. So GBR covered with membrane, and as you can see, using xenograft, sufficient GBR, and I sutured up. And here on the anterior side, biotype was thin, and on the anterior side, I used very thin thread like 6/0 nylon to avoid any tearing and whatnot. So this is how the provisional delivered everything. And as you can see in the follow-ups and healing, black triangle was rather observed to be big. But I delivered after 14 weeks and used ring abutment. After current delivery, the contact point is up to here. So slowly around here, soft tissue migrates and it's being filled up. And as you can see, it's not really visible. So for a patient in her late 50s, early 60s, not much of a problem. It's quite aesthetic. 크게 문제가 되지 않을 정도의 심미적인 형태를 보여주는 것 같습니다. And after 1 year, again, this area, slightly softer recession, it can be observed, but link abutment was used, and zirconia is on the back side, so abutment does not look that ugly. So for this patient, after operation. There was a lot of augmentation, but it was resorbed. And after surgery, only 3 millimeters of the bone remain. But this is quite okay, satisfactory, and can support soft tissue with this, even that bone volume. And prosthesis was then delivered. Now we looked at the anterior maxillar side. We'll now look at the lower part, one case. So for the anterior mandible side, for this patient, we did occlude. There was retainer, and it's really hard to brush teeth or use even clean it. But there's no bone on the even apex for here, and for you can see it's all moving together, and you cannot really use it. So I had to extract everything, and temporary was used, and I had to focus on aesthetics. So using OneGuide system, immediate placement. And after extraction, using guide, implant was placed immediately. So on the lateral incisor side on both sides, and xenograft was used for sufficient GBR, and 1 feet abutment was used, and the membrane can be fixed here, and it's covered the membrane, and bone tech was used to cover it up. And I think this is the sausage sausage technique that you would familiar. So it has a tenting effect. So there is enough space to preserve the materials. And after that, suture it up without tension, deliver temporary. And after surgery, 2 weeks, and after 4 months, again, there is slight recession that continues. So on this area for aesthetics, temporary, continually adjusted to follow the form change here. And after final prosthesis delivered, it's the form needs to be like this for aesthetics. And after 13 weeks, prosthetics, the final ones were delivered. And even after 4 years, on the labial side contour remains, and prosthetics are on a long-term basis maintained to be very aesthetic. So these are the CT photo, and before and after comparison. It looks aesthetic because I think the central incisors, there's no implant, but it had sufficient GBR, which has been maintained, and the gingiva height remained the same on the pontic side. And I think that resulted in this making all pleasing aesthetic results. So before surgery, after surgery, 4 years follow-up. So in the graft side, there's cortical line. So contour is rather maintained very well. So as you can see, so anterior mandible and doing GBR, again, mindful of the bone resorption, do sufficient GBR, use OneGuide system or 1 feet and 1 feet abutment, and using provisional crown together in terms of aesthetics and healing afterwards, and afterwards biological buccal bones form maintenance. I think it's all helpful. If you want to learn more, you can join me in the offline lecture. Thank you very much.